أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم. To all our respected viewers out there, Assalamu alaikum, and depending on what time you are watching this, a very good morning or afternoon or evening to you all. The Central Medical Board of KSI Jamaat Dar es Salaam presents this talk show named Diabetes and Fasting. This talk show is aimed at educating, informing, and reminding our esteemed viewers on the general aspects of diabetes. What is it? What are the symptoms, its complications, the risk factors, prevention, and at the same time merging it with fasting during this month of Ramadan and the implications and various discussions surrounding diabetes and fasting. We have a panel of two speakers with us tonight. We have Dr. ZAINABBAS LADHA, Doctor of Pharmacy, and he is a Chief Pharmacist and Acting Director of Materials and Management at Sri Hindu Mandal Hospital, Dar es Salaam. And I know that he's also part of MHI, Mahdi Health Initiative, which is a community-based group of medical professionals who come together and discuss on various health-related issues and even organize medical programs. Is that correct, Brother Zain? Doctor, is that the correct information? So thank you so much. Yeah, thank you. Thank you so much for joining in, and we are very, very happy to have you. Our next speaker, thank you so much. Our next speaker, in my opinion, needs no introduction, especially if you are a resident of Dar es Salaam. Dr. KAUSHIK is a renowned consultant physician and assistant medical administrator at Sri Hindu Mandal Hospital, Dar es Salaam. And he holds and has held several other honorary appointments, such as Vice President of the International Diabetes Federation, Honorary Secretary of Tanzania Diabetes Association, and he has produced numerous publications on diabetes research and has implemented many initiatives to put diabetes on the health agenda in Africa. So Dr. KAUSHIK, I have 7 more papers of your qualifications, but I think I'll stop here. And I want to thank you so much from the bottom of our hearts for joining us and being with us here tonight.
Thank you for that introduction, and thank you very much for inviting me.
Thank you so much, Doctor. There's one thing that I hadn't realized actually is that so because I see both are at Sri Hindu Mandal. So Dr. Zain, this is not the first introduction, yeah, between you and Dr. KAUSHIK. I am sure, right?
I was in a meeting with him just 2 hours prior.
Oh, okay. So, so this was news to me. That's why. So no, I'm really happy. So I will begin. So I think what I want to request our speakers is we can mute our microphones whilst the others are in talk, and then we can unmute when we are ready. So according to, I just want to brief our respected viewers. According to the World Health Organization, about 422 million people worldwide have diabetes, the majority living in low and middle income countries, and approximately 1.6 million deaths are directly attributed to diabetes each year. But the number of cases and the prevalence of diabetes have been steadily increasing over the past few decades. Diabetes is characterized by high levels of glucose, which is a type of sugar in the blood, resulting into the body's inability to use blood glucose for energy. Two most common types are 1 and 2, with one in which the pancreas does not make insulin, which is a hormone released after meals to help the body use or store blood glucose it gets from the food. With type 1 diabetes, insulin is usually the way forward, and type 2 is when the pancreas makes some insulin, but their bodies don't respond very well to it. And mostly you'll find people with type 2 diabetes on oral hypoglycemic anti-diabetic drugs. Although diabetes is a lifelong disease, it's important to remember that there are many things a person can do to stay healthy. So the aim of this talk show is to enlighten our respected public on the do's and don'ts and further information about this disease, especially on the frequently asked questions that most viewers have. So to begin with, I would like to start with Dr. KAUSHIK. Doctor, for those that are undiagnosed at home, what are the symptoms that one should look out for that will lead him into suspecting that he has diabetes?
Yeah, thank you very much. And the classical symptoms are that you have excessive urination at night, you tend to lose weight progressively, you become tired much earlier, and then you start getting weakness even when you walk short distances, and then you get an increased fatigue. Now, those are the classical symptoms. But unfortunately, many of those people out in the community do not realize that those are probably the early symptoms. Because if you look at a man at the age of 55, 60, and if he's passing a lot of urine at night, his first thought will be that probably I'm developing prostate, or I'm probably developing a urine infection. So you find that there are a lot of variability in the symptoms. But the classical symptoms are excessive urination, weight loss, feeling tired, feeling dizzy, and progressively finding a sort of shortness of breath as you move forward or if you walk long distances. More than 50 to 60% of these people who are undiagnosed tend to come to the hospital with a complication. So they might probably be detected in an eye clinic, which is the major sort of a burden which you have with diabetes undetected. So they go into an eye clinic saying that they cannot see well, and you find that probably they are diabetes and they have an eye complication. Or they come with a diabetic foot, or they have got a gangrene in the leg, or they have a kidney problem, or they have a heart problem or a cardiovascular problem. So more than 30 to 40% of them are diagnosed with a complication as a first diagnosis. And recently, during the first wave of COVID, when we had it, you find that many of these patients came in with a blood glucose of more than 30, 36. And when you ask them, they said they never had diabetes. But probably these were the people who were out in the community who did not know that they had diabetes, or they were probably borderline diabetes. So the symptoms is very variable. Yeah.
Thank you so much, Professor. By the way, have I been calling him doctor? My apologies. It is Professor KAUSHIK. So this is
I'm fine. Whatever you call me, it doesn't matter.
I know, but it does to us, Professor. So I want to take clear this mistake. It's Professor KAUSHIK. Thank you, Professor. Prof, there's one more thing. You very nicely explained the symptoms of diabetes. However, the next question is, now that I feel that I do have some of the symptoms or all of the symptoms of a majority of the symptoms, classical symptoms of diabetes, what is the methodology of diagnosing it? Are there different methods of diagnosing diabetes for a person who wishes to find out?
Classically, the method for diagnosis is those previously used was what we call as an oral glucose tolerance test. So in an oral glucose tolerance test, after an overnight fasting, you come fasting in the morning, your blood glucose is done, and then after that you are given a 75-gram glucose in 300 ml of water, which you drink over a period of about 10 minutes. And then after 2 hours, you check your blood glucose again. And then you come to a diagnosis whether you've got what we call as a normal glucose tolerance, you've got an impaired glucose tolerance, or you've got diabetes. Now that is a classical method, but these days you normally don't use that method much unless you are doing some scientific study. So what we do normally is that you ask a person to come fasting, or even if you do a random blood glucose, any random blood glucose when you go to a clinic, and if you do a blood glucose level, if you've done it in the morning, if it is more than 7, it gives you an index of suspicion when we say 7 millimoles. Because again, you need to be very careful about the units you use. Because if you talk in milligram per deciliter, then the figure is different. If you talk in millimoles, it is the different. So here we use mainly the millimoles. There are those who come from India and come with the glucometers from India. They measure it in milligrams. So when you divide milligrams by 18, you get a millimole. And a normal person ideally should have a fasting blood glucose of less than 6. And then after 2 hours of meal, it should also be less than 6. So that should be basically the normal glucose tolerance. Many of these people also have borderline diabetes, so your fasting would be less than 6, and 2 hours after the meal or 2 hours after the glucose, your blood glucose would be between 6 and 10 millimoles. That is impaired glucose tolerance. And then you have those who have got diabetes, where the fasting could be more than 6 millimoles, or the after food it could be more than 10 millimoles. So those are the ones who have got diabetes. But ideally, you do not confirm the diagnosis with one test. You ask the person to come back after a day or two, unless the readings are extremely high. And the third method, which is used these days, is what we call as a glycosylated hemoglobin. The glycosylated hemoglobin is a test which basically measures the glucose absorption by the red blood cells. And if it is less than 6%, you have got a normal glucose tolerance. And if you have got a borderline, it is between 6 and 7. And if you have got diabetes, it is more than 7.
Thank you so much, Professor, for that briefing. Is there any problem with the voice? Is it better now, Dr. Zain? It's better? Yeah, thank you so much. Thank you so much, Professor. Dr. Zain, I want to come to you now and ask you, there's this, should I call it stigma or this norm amongst people with diabetes? Because in many health centers and medical settings, you'll find that diabetics are discouraged from eating certain types of food. So you will find that a diabetic coming to you and telling you, my doctor told me not to eat A, B, C, D, E, F, and the list goes on all the way to Z and maybe beyond that. So, and many of these diabetics thereafter tend to starve themselves. So they use starvation as a mechanism to be able to control their blood glucose levels. So in your expertise, could you please enlighten us, is starvation the best method to lose weight and thereafter control diabetes? And beyond that, what therefore can a diabetic eat in his or her diet?
Thank you very much. This is certainly a trend that is being picked right now. The current world is in a certain keto diet and intermittent fasting as well. Now, that is quite dangerous, especially when it comes to diabetic population. Because when you're talking to diabetics, you're looking at people who are on oral hypoglycemics, who have very strict control, and you will be surprised that the same people that undergo starvation will come back to the hospital with cases of DKA, that is diabetic ketoacidosis, or HHS at times, so that's smaller hypoglycemic state. So you expect on both ends. It's quite dangerous for a diabetic person to remain starving, especially those that are on type 1 insulin. And that could lead to best case scenario, they'll just fall down and probably have some sugar and get up. But then worst case scenario, they can fall into diabetic coma. You can have all range of types of foods. With regards to diets, there are very specific diets that are meant for diabetic people. And these diets are tailor-made for according to the body type, the nutrition. That's why we have very specific nutrition-based programs, especially for our diabetic patients. What we tend to avoid is foods with a higher glycemic index. So that is especially when you're discussing with your nutritionist, that is where you're addressed. So starches, long-acting carbohydrates have a usually longer glycemic index comparatively to simple starch, simple sugars as well. So the whole diabetic pattern is not only fruits at the most of time, it's all about getting a right nutrition at the right time as well.
Thank you so much, Doctor. The next question, when I wrote this question down, I was struggling with myself. Should I ask this question or not? So now, Dr. Zain, my next question to you might be funny coming from me. So what I'm going to do is I'm going to ask you this question, then close my ears, because my next question is, how important do you think exercise is when it comes to diabetes and the role of exercise in our daily lives? Please.
All right. So this is something that I'm quite passionate about, as it's well known. I'm well known, I think, an ambassador of fitness. Diet and nutrition, as they say, there's a very nice saying that says, your abs are not made in the gym, they're made in the kitchen. So that gives you a terminology that it's 50-50. You need to be able to burn off your calories. So basically, human beings have a basic calorie intake per day. There are lots of formulas that calculate how much calories that you're supposed to require as a basic metabolic rate, based on your resting expenditure for energy, how much you require on your based on activity, if your activity is vigorous, moderate or slow. So all these factors do come in, especially when you have the sedentary lifestyle that is happening across most of the population that we have across Dar es Salaam. Now, the importance of, so I'll talk about this in two steps. One is for the normal people that we all know, that as WHO also recommends, that half an hour of activity per day, almost 3 to 5 times a week, is usually sufficient, and studies show that it prevents a lot of cardiac abnormalities, cardiac related issues, non-communicable disease issues are prevented. When you're talking about a diabetic, you see the types of exercises that are also need to be discussed with the physician, discussed with the nutritionist as well, because it needs to be tailor-made. People on OHAs, as in the diabetic medications, usually may fall into a hypoglycemia based on the type of a drug as well. Now, when you have a vigorous exercise and a scheme that is quite tough, you might need to either tailor down your dosage, or you might need to up your caloric intake. You need to make sure that you're not playing at levels where the body itself tries to shut down or goes into other disorders. So in terms of importance, yes, it's a very well-known fact, like you pointed out. And for diabetics as well, there is no recommendation that ever says that not exercising is the best thing for diabetics. No.
Thank you so much, Dr. Zain. As I mentioned, I didn't hear any of what you just said, anything, but inshallah, I hope our viewers heard this specific answer from you. Thank you, Doctor. Professor, I just want to take us back to the foundation of this talk show, which is diabetes and fasting. A very frequently asked question by those people who wish to fast and are diabetic is that, is it advisable for a diabetic to first fast in the first place in the month of Ramadan? And what would your recommendations be to someone who wishes to fast and is a diabetic?
Okay, thank you very much. I think that's a very important question. And I think the decision of whether you should fast or not fast will depend on how well your blood glucose is controlled. So in a very well controlled person with diabetes, whose glycosylated hemoglobin, let's say, is somewhere between 6 and 8, which is a good control or adequate control, is somebody whom you could probably ask to fast, but then it depends on what medication he's taking. So if I take a very simple example of the common drugs which we use here, if you take a drug like glibenclamide or Downil has got a half-life of around 12 to 16 hours. If you take a drug like Emeril or glimepiride, it has got a half-life of about 4 to 6 hours. And if you take a drug like gliclazide or glipizide, the half-life is about 4 to 6 hours. So if somebody has been on a glibenclamide or a Downil for a control of his blood sugar and is taking 2 tablets in the morning and 2 in the evening, and if this individual is adequately controlled, and if he wants to fast, then there are 2 things you will do. One is that because the glibenclamide has got a long half-life, you might tell him to take his glibenclamide in the evening when he breaks his fast or when he has a main meal. Then at night, if he takes another meal, probably he might take metformin or something, and then in the morning he should not be taking glibenclamide, because if he takes glibenclamide in the morning and then he's not eating the entire day, then you will find that in afternoon he'll go into hypos. So it depends on three things. One, how good is your metabolic control? Two is what type of drugs you are taking. And three, in people who are type 1 diabetes who are using insulin, depending on what type of insulin you are using and how much insulin you are using. So those things will determine whether you can fast or not fast. 50 to 60% of those with diabetes, if very well controlled, can fast, but then you need to adjust their doses based on what medications they are taking.
Thank you very, very much, Professor. Another problem, Professor, with the community in general, or the community of diabetics in general, is that I think they are unaware of the complications that diabetes can lead to, and therefore some might take it very easily or lightly when they have diabetes. Could you please enlighten the viewers on the complications and risks that diabetes can lead and can lead to in a person's life?
When you talk about complications, as I said, in the developing world, whereby, for example, in Tanzania, from the data which is there, for every person diagnosed with diabetes, there are 2 to 3 out in the community who do not know that they have diabetes. And for the person who are diagnosed with diabetes, there is what we call as a cascade of treatment. So of 100 people with diabetes, 30% of them, they do not know that they have basically a poorly controlled diabetes. 30% of them who know that they are very well controlled, normally you find that their adherence or compliance with the medication sometimes is a problem. And then you find only 10 to 15% are very well controlled. And once you have diabetes, your complication cycle starts. And previous studies have already shown that once you have diabetes, by having a good control, you are just delaying the complication. It is not that you are not going to have the complication. So a very well-controlled person with diabetes will start having a complication at 25 years or 30 years of diabetes. But if you are not very well controlled, you can have complication after 1 year or 4 years or 5 years. And the complications are mainly 2 types, what we call as a microvascular, which is a small vessel diseases. These usually affect the eyes, it affects the kidneys, and it affects the nerves. So it gives you neuropathy whereby you feel numbness and you feel tingling numbness in the legs or in the extremities. If you have a problem with the kidney, initially you start having protein in the urine, but later on you start developing hypertension, and then you start having renal failures. And then you have the eye whereby you have diabetic retinopathy, your vision gets affected. And then you have what we call as a macrovascular. In macrovascular, it is a large vessel disease, which usually affects the heart. It affects the brain. So in brain, you get a stroke. In the heart, you get a myocardial infarction or you get cardiomyopathies. And then in the legs, you get the gangrenes and you get peripheral vascular disease. So those are the conditions and the complications which you get. So if you have diabetes, and as you have correctly said, there are people with diabetes who feel that they always boast that with 10 and 12, nothing is happening to me, I'm fine. And in fact, some of the patients come and tell you that if his sugar goes below 10, he feels dizzy. He wants his sugar to be at 10 and 12. But basically that 10 and 12 level is already starting to cause complications. So it is very important to have a good control. And a good control, when we say a fasting sugar, should be between 4 and 6 millimoles. And after food, it should be between 5 and 8, maximum 10, not more than that.
Thank you so much, Professor. Dr. Zain, it's a very well-known fact that you are in the front line when it comes to physical fitness, when it comes to exercise and sports. It is not there is no doubt in that. So my question to you is, what would be your recommendations when it comes to diet for people with diabetes, be it generally and then specifically for this month of fasting?
That's a very important question. As I mentioned earlier as well, that the month of Ramadan involves fasting, and as Professor has mentioned, the diet is tailored automatically. The medication regime is also tailored. The exercise regime also requires to be tailored. Now, when we're talking about what we are saying, as Prof had explained, when you're working out vigorously, so you will definitely have a lower regimen of your insulin or your OHS. So when I say OHS to the viewers, it would mean an oral hypoglycemic. So the glimepiride and glycosides or the any types of diabetic medications, that would be definitely lower when you have a person that is regular and has a fitness level. Now, the current fitness geeks, including myself, we use a lot of technology for monitoring how much intensity of our exercises are. We can also, up to the extent of monitoring our VO2 max, our pulse rates, how high our heart rate goes out all the way during a workout. And that would allow you to understand whether how fit, how good your heart condition is in. Now, during Ramadan, activities vary. There are activities that happen during fasting and the activities that happen after. During fasting, you definitely need to make sure that you are wary of the symptoms of hypoglycemia, because especially during the evening hours when the hours of breaking a fast appear. But then the activities that happen post meals, and that is also something to look for, to make sure that you discuss definitely with your physician, your exercise partners, your gym trainers, because if I take a meal at 7 or 8 and I have planned a tournament at around 10, which is a well-known fact for our community as well, and these people tend to take diabetic medications as well, and the consequence of the long-acting medications would then cause a lower level of glucose in the blood, especially during midday hours. So around 12 o'clock, they start experiencing the symptoms of hypoglycemia, and they end up having to break their fast before they can complete it. So it's a thing that has to be tailor-made, and it's something that needs to be taken with a lot of caution as well.
Thank you so much, Doctor. There's also one other thing when it comes to nutrition and the month of fasting, is that you'll find majority of families, and probably some of us as well, we tend to break our fasts with dates. And there are certain families that if khajur na hoye to probably they will even prolong their fast until and unless they get the dates to break their fasts with. So my question is, are dates healthy when it comes to people with diabetes, and what does research say regarding this?
All right, this is a question I believe also Prof has a lot to chip in. We've had a lot of major discussions, especially regarding fruits and NCDs. And now, when you're talking about fasting, and you talk about the time of iftar, the breaking fast, and you definitely know that you need to take dates, and that is a recommendation as well. Yes, it's quite advantageous as well. However, dates are a polysaccharide. However, they have a lower glycemic index compared to the usual. Now, I feel I might be controversial to some, but it's a thing that I might have to talk about it as well. So the whole thing about Ramadan is oily foods, deep fried foods, and without those, especially, that is where the iftari doesn't happen. So yes, dates, good choice, healthy, natural, in definitely in moderate amounts. However, the accompaniments that you have in the meal, along with the rest of your entire meal, that will cause quite a trouble as well. So that is something that we need to be aware about.
Thank you, Doctor. Professor, Dr. Zain just mentioned your name. So I just want to now request you if you have anything to add on this, because I'm sure this question has been posed several times.
Yeah, you see, I believe, as Zain had said, is that any food you take in moderation you are fine. Dates, whether you consider it as a pure sugar, or you consider it as a fruit, or you consider it as a what we call as a one of the sweet dishes, or whatever the case, as long as you take it in a smaller, moderate amount, you are fine. And in fact, in some of the countries, in people who are very well controlled with diabetes, they even tell you that you can even take a bit of a sugar occasionally. If you want to enjoy yourself, you can enjoy yourself, provided you know that to what limit or what quantity you should be taking. So the question here is, how well are you controlled? 2 is, what is the quantity you are taking? And 3, when are you taking it? So if you have fasted for 12 hours or 14 hours, and then if you are taking a date, or 2 or 3 pieces of date, or about even 6 pieces of dates, you see, it's not going to create your blood glucose to go extremely high, unless there is an individual who is sensitive to the dates, and his glycemic index can go up. But otherwise, I do not see any problem with 2 or 3 dates to break the fast. I personally don't think that's an issue.
Thank you, Professor. Another honey is another topic of discussion. So I want to request you to please even elaborate briefly on that as well, please.
You see, it's good you're bringing it up, because you see, when we talk to people with diabetes, we tell them 4 or 5 cardinal principles of the diet. Because sometimes when you go to the nutritionist, I hope nobody's listening, but they normally tend to confuse you more than to help you. So you find that there are simple 5 principles. 1, you need to avoid the direct sugars. So if you are taking direct sugars, which is sugar, honey, and jaggery, which we call in Gujarati gur, you see, these 3 things, you should avoid them. 2, you should avoid fruit juices, because fruit juices have got fresh fruit juices. Even if you don't put sugar in it, they've got a very high glycemic index. So you need to avoid fruit juices. Occasionally, if you take a glass or a half a glass, is okay. But if you take a lot of fruit juices, the sugars will go up. 3 is that don't mix the fruits together. No, don't eat a fruit salad. You take one fruit at a time and spread it out. So you can have an orange in the morning, a banana in the evening, a pawpaw in the evening, it's fine. But if you take 4 or 5 mixed fruits together, your sugars might go up, depending on your sensitivity there. 4th, you control your carbohydrates. Carbohydrates should not be more than 1/4 of your plate. You see, if you are able to control the carbohydrates and don't mix the carbohydrates, take 1 carbohydrate at a time, that should be fine. So if you follow those simple basic rules, you are fine. Question is the quantity, whether you take a big dish or a small dish or an average dish, and what is your quarter size. That is what you need to be careful. Now, coming to honey, a lot of people with diabetes, there is this belief that honey does not increase the sugar. Basically, honey is a direct sugar. So if you are well controlled with diabetes, and if you take 1 or 2 drops of honey in your tea or in your sugar, in your milk, you can get away with it. But if you take a tablespoon of honey, then your sugars might go up. So basically, for me, honey is a direct sugar. But if you take it in 1 or 2 drops just to sweeten your tea or sweeten your coffee, that's fine. But you need to watch your sugars if you are well controlled.
Thank you so much, Professor, for enlightening us on this. Prof, if I was to take a list of the most frequently asked questions when it comes to diabetes, I think this question would top the list. And the question is, if precautions and measures and medicines are taken, can a person with diabetes lead a normal and healthy lifestyle? Can he still have a family, a career, and a full life just like anyone else? Part A. And part B, if you could kindly share with us maybe a history of one of your patients who managed to control his or her diabetes and was totally and is living a totally healthy and normal life.
So let me start with the second question. The second question I remember very vividly, which I cannot forget, is a baby who was brought to me 8 months old, and she was diagnosed to have diabetes. This is from Zanzibar. And the reason the parents found out that the child had diabetes was because they were usually using disposable nappies. And it came to a point whereby the mother had to change more than 10 to 12 nappies a day because of the excessive urination. And the father said that, look, I cannot afford these disposable nappies. And then somebody told them that probably this is a urine infection. And when they did the urine test, they found that the glucose was extremely high. And this glucose being extremely high, you see, then they came down to Dar es Salaam from Zanzibar, and then we made a diagnosis of type 1. That is the youngest child I can remember whom we have diagnosed with diabetes. This child has grown up, and today he's a professor in mathematics in one of the countries, in one of the states in the US, and still communicates with me. And he's basically grown up into a very well molded, very intelligent person who has become a professor in mathematics. And he's still on insulin. Of course, now being in the US, he has got state of art. He's on an insulin pump. He's got very well controlled. His HbA1c is at around 6.5, and he's doing extremely well. So coming from a very poor family where they could not even afford insulin, and we had to actually supply them donated insulin. So I think if you have a will, and if what is important with people with diabetes is the family support, especially in children with type 1 diabetes. When they get diagnosed, it is the parents who get more shocked than the person himself or herself. And if the family psychologically does not tune themselves to support this child who has a type 1 diabetes and who is going to take insulin for the rest of his life, then the life of that child will be terrible, because he'll always be under depression. He'll always not flourish the way he should, or she should, and you find that is an issue. So the family support is very critical. And I think any person with diabetes can live a normal life, can live an absolutely normal life, can bear children, can have a good family life, can have a best of education, and can succeed in life, provided basic principle is you control your lifestyle so that your blood glucose is controlled. If your blood glucose is not controlled, then you are shortening your life by having a poor control. Coming to a control, or this one, you see, there have been studies which have shown, which I think Zain also mentioned previously, where people have starving. There are people, for example, when we call off type 2 diabetes, which is lifestyle related, type 2 diabetes, you've got 3 or 4 categories. One is where you've got a strong family history, either father or a mother is diabetes, and you develop diabetes. So you've got genetical inherited diabetes there. Second one is type 2 diabetes, which is secondary to drugs you take. Sometimes when you're an asthmatic, or sometimes people with HIV, those who take drugs, they tend to develop diabetes because of the long duration of use of other drugs. The third one is whereby it is your lifestyle. You are enjoying your life, you are supposed to be 60 kilos, you become 110 kilos, don't exercise, you enjoy your life, you become diabetes. So if it is lifestyle related, if you come back to normal weight, if you do proper exercise, you don't even need medications. You can control your blood sugar without any medication. It is what we call as just lifestyle modification. So diabetes, type 2 diabetes is reversible in people whereby it is related to lifestyle. But in people who have got a genetic inheritance, or those who have got type 1, you can do a better control. And there's a lot of drugs which are available whereby you can have an excellent control and live an absolutely normal life.
Thank you so much, Professor, for your answer and for the practical example of the patient that you had. Dr. Zain, when it comes to non-adherence or non-compliance, you will find that this happens with hypertension as well. But with diabetes, you will find that people will often skip their medications. And nowadays we have the machines at home, the glucometers at home, and you'll find that someone checks his blood glucose levels, and he or she sees that it's in normal bounds, and they come up with the decision that today I will not take my medicine, let's see tomorrow. what risk do you think that what threats do you think that this type of behavior might lead to?
Thank you. This is, I think, a very important question, especially with non-communicable diseases. You see, the our bodies are, very simply put, there are two types of pipings or systems that we have. One is the plumbing system, and one is the electrical system. Now, the plumbing system, that is the blood vessels where everything goes through, is where the majority of the issue is, where, especially in diabetes, is where it's concerned. So people with diabetics, with diabetes, and those that are not taking their medication. So there are two terminologies that are used. One is compliance, and the other one is adherence. So compliance is sticking to the same schedule. Adherence is actually taking the medications. Now, 100% adherence and 100% compliance, these terminologies can be interchangeable, would lead to a very good control. Now, studies recently have shown that an intensive, especially early diagnosis, an intensive control of blood sugars using high dosages has shown long-term slowing down of macrovascular complications of diabetes. So when we are talking about microvascular and macrovascular complications, we are talking about what Prof has mentioned earlier: the retinopathy, the issues that happens with the eyes, the numbness sensation that people get, that is the neuropathy. So all these, the nephropathy, as well, the issues with the kidneys. So all these issues can be prevented. Now, why do I say plumbing? Is because, you see, whenever there's a buildup of glucose, especially in our bodies, there are these molecules that are formed that is called AGEs. It's one of the hypotheses of why diabetes causes complications. So these AGEs are advanced glycosylated end products. They cause oxidative stress, and these cause damages. Now, as a pileup, as we see in our sewages as well, whenever there's a pileup, we see over leakage, overflowing, or streets get pooled with a lot of water, and that is the condition that you expect in diabetes as well. So AGEs will cause damage. AGEs will cause buildup of sugar. That in turn will cause poor control, and that you will lead to a very different lifestyle compared to the person that is very strict on control. Now, I see two questions here. The one that Prof had talked about was honey. Now, the other question was regarding patients who are taking beta blockers, especially for diabetic patients. Now, since we're in the focus of Ramadan, it's a well-known fact that there's this condition called masked hypoglycemia. So your symptoms of hypoglycemia would anyway resemble uneasiness and increased heart rate, and you feel sweatish. And these are usually good signs, because you can, as a diabetic, you would easily recognize that these are symptoms that are my low blood sugar levels, and I would need to break my fast in order to avoid the hypoglycemia. Now, beta blockers have a tendency to block this situation. So this is something that needs to be taken with a lot of consideration. You really need to discuss with your physician or your pharmacist before you actually decide to fast, and when your diabetes is poorly controlled. Now, diabetic foot is another major complication that usually happens when you don't have a lot of compliance or adherence, and it's the same scenario everywhere you go. You don't maintain your car engine, and you expect engine trouble. So your bodies also respond the same way.
Thank you so much, Dr. Zain. Doctor, another question posed to you is that I want to ask is with regards to having a plan B. Right now, in the world of technology and advancement, we have a plan B for many, many things. So, for example, if I need to go somewhere, I can't attend a live session, plan B would be online. When it comes to sugar as well, we have plan B nowadays in the form of sweeteners. So this aspartame and neotame and sucralose and all these type of things. What is in your viewpoint? are these sweeteners better than or similar to or worse than? Do they have any effect compared to the normal sugar that we are taking? And what advice would you give to people with diabetes to take this when it comes to taking such sweeteners in their tea or in any other type of beverages?
So there are multiple studies now that are upcoming. The artificial sweeteners that are found in tablets forms or powder forms are usually much more safer than those that are found in fizzy drinks. So you'll find Coca-Cola with artificial sweetener. Now that requires a tremendous amount of aspartame, or so that would cause. You see, these are artificial at the end of the day, and they might mimic the taste buds. They might trigger your taste buds to have a taste of sugar, but they do not have the same effect as the lower the sugar that we usually use. Now, they don't have a glycemic index per se. However, in the long-term usage as well, it's not highly recommended, since some of these studies have shown that they might lead to cancer. They might lead to, because anyway, anything that's artificial will cause some form of damage.
Thank you so much, Doctor. Professor, coming back to you, there's one question that has been posed by one of the members with regards to checking one's blood glucose levels. So two-part question. One is somebody who does not have diabetes, the general public. How often would you recommend them to check their blood glucose levels? And B would be somebody has been diagnosed with diabetes. How often should he or she check?
Interesting question. I think for a general public, depending on what age group you are, there's something which you call as a medical checkup. You take your car to the service and you find exactly is there something wrong or not. So beyond certain age group, beyond the age of, let's say, 45 or 50, whatever you decide on the level, it's good to do once a year checkup just to see that you do not have blood glucose, or you don't have cholesterol, so you don't have any other issues which might be starting in the body. But then the most important thing here is that in a family whereby there's a history of diabetes of a parent or a sibling, you are already at a risk. So for you, it is better to start checking out your blood glucose values much, much earlier than in a normal individual where there is no family history. Second thing is somebody who is an overweight, who is not doing any exercise, or the level of physical activity is very low, then you find that there is somebody who is at a risk. So we call it as a risk population, and those who we consider as a healthy population. So if you ask somebody like Zain, to do a blood glucose check, you are wasting your strips, because you see he's spending more energy than he requires, and he does not require to check his glucose till he's 55, 60 plus. But if I look at somebody who has got 90 kilos or 100 kilos, then he requires blood glucose checking much, much earlier. So I would stratify it in those who are at a risk and those who are not at risk. Those who are not at risk, ideally at an age of 45 or 50 plus, they should do at least once a year. For those who are at risk with the family history, getting symptoms and this thing, I think they should do it more frequently. So this is for a population. When you talk about those who already have diabetes, those who are with type 1 diabetes, who are using insulin, depending on what type of insulin they're using, ideal recommendation is that they should be doing the blood glucose 3 to 4 times a day. But it is expensive. It is sometimes quite cost this thing, so people don't normally do that. But at least twice a day is better to do it in people who are using insulin. Those who do not have insulin, are not on insulin, but are on oral hypoglycemic type 2, and who are very well controlled, you can do it 2 or 3 times a week. Ideally, what I advise my patient is that do a fasting, do 2 hours after breakfast, 2 hours after lunch, and 2 hours after dinner. If you can do these 4 readings a week, you are fine. Because usually what we do is we check our blood glucose only fasting. Fasting does not give you a true indication of how well your blood glucose is controlled. Because in majority of the patient, it is after the food, how well is your blood glucose controlled, that determines your complication. So 2 hours after breakfast or 2 hours after lunch or 2 hours after dinner is something which you would like to check to make sure that you are well controlled. So depending on type of diabetes, depending on how well you are controlled, you can actually decide the levels you want. But nowadays there's quite a bit of a technology where you have what we call as a CGM. Just like insulin pumps, you've got a continuous glucose monitoring. It is like a Walkman device. You connect yourself and it has got a sensor, and you can just check your blood glucose. Either you get your report on your mobile phone or you can get it on a glucometer without puncturing your finger.
Thank you so much, Professor. Professor, I noticed one thing. I don't know if Dr. Zain noticed it as well. When you said certain people who are 90, 100 kilos, you looked straight at me, but that's fine. We'll no. Thank you, Professor, for your very efficient answer. My last question, Prof, to you is, and this is the million-dollar question. We have talked about the etiology. We have talked about the symptoms, the risk factors, complications, and various aspects of fasting and diabetes. But we haven't addressed, or we need to address the final part, which is prevention. Thank God I, for example, am someone in the community does not have diabetes. What measures should I therefore take to prevent it from occurring?
Follow Zain. That is all. Simple rule. Okay, I think what is important, and this is basically related to all the non-communicable disease, where diabetes is one of them. When we talk of 4 major diseases, we are talking of diabetes, cardiovascular, we're talking of cancer, and we are talking of lung diseases. And nowadays, there's a component of mental health. And all these 5 conditions, which we call as a non-communicable disease, you've got a common risk factors. The common risk factors basically are nutrition, whether you are overeating more than what you should be eating. 2, your bad habits, whether you are smoking or taking alcohol. 4 is the level of physical activity. You need to do a certain degree of physical activity on a daily basis. And 5, it is your weight and what we call as overall weight and degree of obesity. So it is food, it is exercise, it is the level of activity, it is alcohol, it is smoking, and currently now we are talking of environment. Environment is also one of the key risk factors which actually cuts across all these 5 conditions. So all these are preventable, and 90 to 95% of non-communicable disease are preventable provided you follow what we call as a good lifestyle. A good lifestyle is you do at least exercise half an hour. You don't need to run or you don't need to jog. Just good fast walking of half an hour 5 times a week is sufficient. You take controlled food, which is a controlled carbohydrate, controlled fats. You make sure you take a lot of vegetables and a lot of fruits. You avoid smoking, you avoid alcohol, and maintain your weight. You will never have these diseases at all.
Thank you, Professor. Thanks a lot. Dr. Zain, I want to request you for any last comments, recommendations, words of advice you would like to give our viewers when it comes to the topic of diabetes in general or diabetes and fasting.
Thank you. One particular thing before I have my final say would be the intake of water, especially during Ramadan, is quite challenging. We live in a tropical climate. There's a lot of humidity. How much water should you be taking? You'll see people gulp down 1 or 2 liters straight away. That does nothing. It literally, you will go to the loo in the next 1 or 2 hours, and you will probably remove everything that is. You need to have like a little bit every half an hour, every hour or 2 hours. Yes, it's quite tough, especially in the month of Ramadan, but 2 liters to 2 to 3 liters especially would be sufficient. And hence the mention of vigorous exercises. So if you are a professional athlete, a person that requires to play during this month, yes, it's quite recommended that you make sure that you monitor your water intake. You make sure that you look out for dehydration, because dehydration, when you combine that with poor control. So if you have HHS, you get hospitalized due to an HHS coma or a diabetic ketoacidotic coma, and the consequences are quite tough and detrimental as well. So emotionally, financially, physically. So these are things that you really need to cater for, and you need to listen to your body more often than, especially when in this month. Now, one thing that that was asked as well: how frequently should people with diabetes go for checkups for the eyes or retinopathy, just to or diabetic foots or neuropathy? They should at least have that once a year, or biannually, that is once every 6 months. You need to have a periodic checkup just to make sure that you are in line, everything is going on smoothly. And I think the best advice is what Professor said, but slightly on the opposite end. Do not be me, be Professor. As you can see, amounts of knowledge is enormous. Just go to him, give you the best of advice. And he has lived an amazing life so far, and he has not even a single complication. And that just tells you that the level of discipline that you require is something that I would also like to achieve, to get there, so that all of us, when we cross 60, we do not have any other complication.
First of all, thank you, thank you, Doctor. I don't think Professor has reached 60. It doesn't look like it. But if we were to assume that he is 60 plus, then yeah, I agree with you. Hashtag follow Professor.
I'm 60. For your information, I'm 66 now.
May God give you a very long life, Professor. Thank you so much. Thank you, Doctor. Professor, on your end, any final words or recommendations, advice that you have?
Yeah, I think, first of all, thank you for giving me this opportunity. I think it's a very important topic, and usually during Ramzan, people tend to get confused. And as we mentioned, that living with diabetes is not that you are sidelined from your normal life. You can have a normal life, you can live a normal life, you can do all what everybody is doing, eat what everybody is eating, provided you have your own discipline and you have your own control. And it is possible to do whatever you want, whether you have type 1 or type 2, it is achievable, provided you are committed to make sure that you control your sugar well and you do what is required to be done. That's all.
Professor KAUSHIK, Dr. ZAINABBAS, on behalf of the Central Medical Board, I want to sincerely and personally thank both of you for taking out your precious time and joining us. And I sincerely believe and hope that our viewers and the public will benefit from this knowledge that you have shared with us. So asanteni sana, and we hope to have such sessions with you in the future as well. So thank you very, very much for your time.
Thank you very much. It was a pleasure having you.
Thank you very much, Imran. I think this was very useful and timely.
Asante sana.